Excuse me, everyone. We now have our speakers in conference. Participation in this call is by express written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off the webinar if the AHA did not expressly invite your participation. Please be aware each of your lines is in a listen-only mode. At the conclusion of today's presentation, we will open the floor for questions. At that time, instructions will be given as to the procedure to follow if you'd like to ask a question. You may also submit your questions electronically at any time using the Q&A pod located to the right of your webinar platform. You may also download a copy of today's presentation from the Files pod located directly above the Q&A pod. I would like to now turn the conference over to Ms. Rebecca Cheeky.
Thank you, Stephanie, and welcome to everyone who has joined us today. This is another in the Executive Dialogue Series of the American Hospital Association on best practices in behavioral health care. The title for today's webinar is Missions Health's Journey to Addressing Increasing Behavioral Health Needs in the Emergency Department, or more succinctly put on the slides, Mission Health's Behavioral Health Emergency Services. It is my honor today to first and foremost thank all of the speakers who are joining us, but to introduce Sonia Grech. She is the Senior Vice President of Patient Safety Net Services and Behavioral Health at Mission Health, and I'm going to turn the floor over to her to allow her to introduce the other colleagues who are with her to spread light on this challenging and interesting topic. Sonia, please go ahead.
Thanks so much, Rebecca. Good afternoon, everyone. It's an honor to be here. I have a group of folks with me as we discuss this conversation because this truly is one that illustrates that it takes a village to address our behavioral health population and how we work with emergency services. First, I have Dr. Rick Zinn here. Dr. Zinn is our chief psychiatrist of our program, addressing the inpatient component and overseeing our behavioral health program. And then we have Dr. Corbett. Dr. Corbett is one of our emergency department psychiatrists that, again, will be adding some insight today. Rick Lee is a registered nurse and the executive director of emergency services for Mission Health, not only looking at Mission Hospital proper in Ashville, North Carolina, but throughout Western North Carolina. We'll talk about that as we have community hospitals within our system as well. We also have John Wood here, and John is one of our partners from a performance improvement standpoint that does a lot with our data collection and helping us to tell the story, and is definitely integral to the team. And then Mary Worthy. Mary is our director of access for behavioral health patient care. She does a lot on the intake side as well as, again, working with processes throughout our system to really address our behavioral health population. So again, our goal is to briefly go over some of the slides that you've received, and again, to engage in dialogue and be able to answer your questions. We're very aware of the fact that you want more interaction, and so we're just going to take it from there. Just a brief opening about Mission Health. We've been here for about 130 years. We're in Ashville, North Carolina, which we're serving Western North Carolina, which are 18 to 23 counties in the far west here in North Carolina that are very rural as we work through the needs for our patient population. Our goal is to really focus on providing quality care throughout our region, and we do that from a community to tertiary quaternary care services. We employ over 12,000 professionals. We have 6 different hospitals. We're licensed for over 1,100 beds. And we employ over 400 medical providers, and more than 2,000 total physicians are on our medical providers are on our medical staff. And again, we're really dedicated to improving the health and wellness of our population in Western North Carolina. We have a map that we wanted to share with you, and this kind of shows you Western North Carolina, the 18-county service area. Over 800,000 population that we serve, and you can see a pretty significant population over 65. And again, we also have, beyond just our inpatient hospitalization or hospital programs, primary care and secondary care that we provide specialty services throughout this region. Just to the next phase is really looking at our org chart. Wanted to make sure that you had an understanding of who we are. At the very top is Dr. Ron Prowlis, who is our president of our system of Mission Health, and Ron has been very supportive in the work that we do for behavioral health, and it's really been present with us through this stage as we look at our services and where we need to go, as well as board support. And I think if the one message that I could get across is having that leadership support in your organization is really important to setting a pace and a different focus on your program. I had the opportunity to report directly to Dr. Paulus, as well as I work with Dr. Jill Hogarth-Green, who is a PhD that is our president of Mission Hospital in Asheville, but also Chief Operating Officer for the system, as well as I work with Karen Olson as our CNO here at Mission Hospital. At Mission in Asheville is where our inpatient program is. We have 58 beds that are here serving peds, adolescents, adults, as well as geri patients. So we really pull that piece out, but it's a lot of system work. And I won't go through the details of all the specifics of this org chart except to direct you to the left side. And this is our nursing arm. As you can see, Joe Frankovich and his team that is supporting the nursing, as well as some of the work that we do in discharge planning. Dr. Zinn is in the center as the inpatient support and medical lead for our psychiatric program. And we also have our psychiatrists are employed with Mission and a practice manager that works with them. And along the bottom, I think it's really important to point out we have IT support, quality support, and finance support, and really making sure that we have a solid team to support us in the work that we do and understand our program from a business perspective. Something a little bit different to the right is Dr. Jim Hardy. Jim is our medical director for behavioral health community services. He's a family practice physician that's worked in the FQHC settings, understands the homeless population, and also prior to Dr. Zinn getting here, worked quite extensively on the inpatient side with our psychiatrist as well as our program, and really understands the full continuum with behavioral health. And he's been instrumental in some of the community work that we do in integrating behavioral health services in our primary care and specialty practices. And then you can see Mary Worthy, who heads up, again, intake and access. We have Safety Net as part of this program, and then our ambulatory perspective of integrating into our practices. And then we have an SOP program here in Asheville, as well as one at a member hospital, supporting the work that we do in the community. So significant support from the leadership and the board of Mission Health as we have been on the journey for the last 4 years of learning, understanding, and trying to see clarity from other folks. We certainly do not have the answers. We, I think, can all align in the challenges, and we want to share our journey and, again, learn from others as we do not have all the answers to the challenges that we all face. With that, I'm going to shift us to the challenges in the ED, and I asked Dr. Zinn to really kind of head this project or this topic off for us, as well as Dr. Corbett in addressing those efforts.
Thanks, Anya. So I got to Mission in May of 2016 and had interviewed to come here the prior fall, and I have to say I was a little bit intrigued and scared when I saw the numbers of boarding patients that we had at that time. It was really something that I hadn't been used to, although I know this is a problem around the country. Here in North Carolina, it's perhaps a problem, a greater problem than in some other areas, and much of that is due to state hospital beds. Our absolute numbers have decreased, and those beds tend to be taken up by forensic cases now. So our access has really decreased over the last 5 years or so to be able to get chronic and persistent mentally ill patients who require long-term care to state hospitals, or very acute patients who really are not easily stabilized in an acute setting to the state hospital. So that's been a challenge for us. We also had just an increased volume to our emergency department. in the time frame from 2012 to 2017. That is stabilizing some, and that may be due to some community efforts that we've made, and we'll talk a little bit about that down the line. We're not the only ones with this problem. Other hospitals are too, so our ability to transfer to other hospitals has been limited. And in addition, we just have had an increase in acuity. Those patients that may have gone to the state hospital in the past, we've been in a position where they're here, they're in our emergency room, and there's nowhere else for them to go. So we've had to learn how to treat them in our setting. We've also had changes related to that in our patient population. Asheville is a pretty desirable place. Our numbers of tourists increase significantly in the summer months, and our boarding tends to increase a bit during that time too. We get a fairly high indigent population, and related to that, we have a lot of housing challenges in our area. So these kind of combine to lead to an increase of people presenting to our emergency rooms. As elsewhere, we have a huge problem with substance use disorders here. Our opioid epidemic is hitting us in full force, and kind of lost in the shuffle is ongoing problems with alcohol and certainly with methamphetamine and cocaine. So that runs the gamut, and many of these patients present with psychiatric presentations in addition to their substance use problems. We also have comorbidity with intellectual and developmental disabilities. And this is a particular patient population that can lead to difficulties in terms of placement. And for many of them, the inpatient psychiatric unit isn't necessarily indicated or helpful, but finding the right location for them is sometimes a challenge. And often they have had to sit in our emergency rooms for way too long as we try to get appropriate placement. Prior to this, there was minimal treatment in the emergency room setting. The ER was a place to wait until somebody could get more definitive treatment in the inpatient unit. But with the change in population, we realized that we had to treat patients in the ER. Otherwise, we would be left with very acute patients and a lot of challenges within that setting. In addition to all this, as everybody's aware, we've had a flu epidemic this winter. We've had increasing challenges in terms of medical surgical volume, and for that reason, we have to be very mindful of getting our patients through into appropriate settings for them so that we can, not clog up the ER and get in the way of the necessary treatment that goes on the medical and surgical side. So that's created, kind of even more pressure for us to be able to manage our population well.
I would also add, and Rick Lee, you may want to address this, as the nursing leadership of the emergency department. I think that, as always, there was just that lack of understanding and expectations from the ED staff with our behavioral health staff. And again, we've done a lot of work to try to really align in understanding what it meant to have a patient in the emergency department and how we could address that.
So this is a graph of our numbers, our average boarding numbers over the months since 2014. And this includes both Mission Hospital and our regional facilities. The numbers have actually grown in both places, but the vast majority of these numbers are Mission Hospital itself. We're by far the largest. As you can see, it has kind of leveled off. It's become a little bit more predictable in terms of our numbers over the past year. Still challenging, still high numbers, but it really had been increasing from 2014 to 2016, and based on the increases, we were concerned that it was just going to keep going. The slope of the line would not level off, and that's really what we've been trying to address, is how to provide actions to prevent that from happening, from the numbers just continuing to go up.
Sorry, I was just going to say, we are big here at Mission Health and really looking at a driver diagram, and it's basically trying to understand what is the aim or the goal, and then what really supports that. John, I don't know if you want to talk a little bit about driver diagrams first, and then we'll get into the different components.
Sure. So a driver diagram, for those of you who may not be familiar with it, is really looking at what goal are you trying to accomplish. And in this case, of the slide, that what you'll see on the slide is that we're constantly improve Mission Health's response to behavioral health needs in the emergency department. And then there's generally a handful of what we call primary drivers. that will result in that outcome or that aim that we're looking for. What we do after that is break those primary drivers down into secondary drivers that support the primary driver, and then what follows that is a list of actions that accomplish that work toward those drivers to accomplish the goal. So it's a way of taking a large amount of activity, breaking it down in particular buckets so that everybody is looking at this from the same page and that we're all aligned as we work together to make improvements.
So with that, I think one of the primary drivers, and I've alluded to this and talked about a little bit, is the leadership. And again, it's evaluating resources and what are needed. And we really looked at what we're reinvesting on really the end point of patients coming in, holding them in the ED, how we were addressing things, and what we could do upstream. And so our goal was to begin taking some actions to begin a new process, and that's where our medical director leadership on the inpatient was really important. We put together an ED and behavioral health oversight committee, and that was, again, so that our physician leads and our operation leads could come together with staff members and really talk about and have aligned expectations. And I think that was really key for us to begin talking proactively versus waiting until a negative reaction or expectations were not met. And data is always important for us, and we spent a considerable amount of time, and John has really been on point with helping us to get very clean data and data that is reliable and credible, so we understand where we are as a system from the patients and the patient population, as well as the outcomes with our patients.
Right, and the second driver that really has been crucial, obviously, is care for the patients. How do we provide care in the best way possible, given the population that we have? And we have a lot of partners involved in this, our psychiatric team, our intake team, who works very closely with us, our nursing team in the ED, as well as our telepsych team. We have a contracted telepsych function that we utilize after hours that's been helpful because they serve as kind of a pressure release. You know, they're able to see additional patients when we get very crowded. We had space limitations that we had to address. We decided to get clinical interventions together to help treat the population, and throughout all this, we focus on safety as the secondary drivers. Over time, we've developed some specialized behavioral health boarding areas. The first was a 5-bed area in the ED proper, just adjacent to the ED, and that's kind of for our most acute patients. Also, in the Mission Hospital proper, we developed a unit called B3 South, which was initially a clinical decision observation unit, a medical observation unit, but because of our bursting numbers of patients, we had to start housing some overflow behavioral health patients there. And over the past 2 years, essentially, it's mostly been a behavioral health unit, up until recently when we have had some times where it's gone medical again. On the other side of the street, near where our psychiatric units are, we have 2 psychiatric evaluation areas. Initially, we had one that was 5 beds, and that's increased over time to 2 units with a total of 23 beds. So we've had to develop a lot of different spaces. Those 2 psych evaluation areas are psych safe. They don't have all the full components of psychiatric units, so they're not adequate as inpatient space, but they do serve our function for holding patients in a safe setting. They're staffed by behavioral health nurses, techs, psychiatrists, FNPs who do the medical needs of those patients, and mental health clinicians. We do daily rounding there. Both our licensed clinicians see patients daily. They actually do run some groups even in that setting, and our psychiatrists round daily and actively manage those patients. Because of this, we've been able to discharge more patients from our emergency room settings. Our rate of discharges has increased over time, and there's a slide in the appendix that shows that.
Yeah, I was just going to shift us a little bit. We don't want to read everything to you, just kind of highlight some things and make sure that you guys have plenty of time for questions, but really the community engagement, again, so important here for us in pulling agencies and providers and law enforcement together. And we've been pretty successful with, again, a lot of leadership and being not just leading, but a leader participant in group efforts, so that our organization was not seen as the solution, but the solution was within the community. And having our medical director there and myself in my role really beginning to talk about strategy. And we've been pretty successful in some of our efforts. We've opened a behavioral health urgent care that is a community model with the peer support living specialists, or living room with specialists in it. We have 8 recliners that, again, that can be a place for someone in crisis to have 24 hours to be evaluated. Upstairs, it has a community pharmacy in it, as well as NAMI and other agencies, outpatient services, to really begin supporting individuals. And it has a place so that in our community, people have a place that they know where to go, because before we heard, we don't know where else to go but to the emergency department. For us, it's really important that we talk about other efforts that we're doing. So we spend a lot of time in really pulling the community together as quickly as we can, and then also focusing internal on the culture. And that's really having a shared vision within Mission Health of our patient with trauma-informed care and de-escalation. So really moving that process along, and if you look at our timeline, it can just show you the various efforts that we have been working since 2015. A lot of work with this has come up that you guys could probably align as well. Again, I'm trying to make sure you have plenty of time to ask questions. So just see that every year it's been strategic in our approaches. We built from year to year in our efforts, and 2018 is a big year for us as well. And then I don't know if, Rick, you want to talk a little bit about the data.
I will, and I just wanted to highlight one other thing, and that was hiring a dedicated ER psychiatrist, which really has helped us to get at things on the front end, get psychiatric evaluations done sooner and more towards the front end. That's been invaluable in helping with being able to discharge more patients from the ER setting appropriately and getting them the treatment they need. So you can see from the next slide that over time the slope has increased in our percentage of patients that are getting discharged from the ED proper, and our slope on the next line of the length of stay in the ED proper. So this does not include our hold areas. You know, this is in the ED proper, and it's in hours on the left, as you can see. So in the past, we were kind of clogging up things in our emergency room, and over time, we've been able to reduce the amount of time that patients spend in the ER proper, as we either evaluate them and either get them ready for discharge or get them to the next level of care. Mary, maybe you can speak real quickly about our CH intake response time.
Well, so one of the things we did in the emergency room was we started looking at processes on how to get the mental health clinician involved quicker. And so right away, when a patient is at triage, when they're being triaged, they flag whether the patient is a behavioral health patient, and if so, then our mental health clinician receives a text page alerting us that that patient is in the emergency department, and then that allows the clinician to respond rather quickly. And we have 2 different entrances that somebody can come in, so it gives the patient name and the provider and tells us where the patient is. And so what we've seen is the second graph, the behavioral health intake clinician page to initiate assessment. That's where we've really seen that decrease, because we're hitting it at about 12 minutes now, and that's including, you know, we only have 1 behavioral health triage clinician, so they could be meeting with the patient, but we're getting to that patient as soon as possible, which helps us to identify whether this patient can be discharged quickly with an outpatient appointment or whether they need further evaluation. But we're really identifying it on the front end as quick as possible so that then that patient can be assessed in a more timely manner and discharged if possible.
Thank you so much, first of all, for taking such incredible and innovative time to work with a often challenging group of patients. It is clear that the name of your organization and the culture there truly is all about the mission to help improve access to high-quality care to all of those who seek it through Mission Health. So thank you so much for all of your work in this, again, challenging endeavor, but also thank you for your willingness to share with the field. Any last comments before we wrap up this time?
Yeah, I would just say thank you for allowing us to share our story, and again, just reiterate that, it's just our story. We would love to hear from others and what is happening within your organizations to share, because we certainly don't have the answers. We have an innovative culture and an innovative community, and we've been very fortunate that we've come together and worked well. But again, we're always open to learning and sharing, and by no means have the answers, and definitely would love to learn more from others.
Thank you. Well, thank you all for participating today. I hope you found this informative, and have a great week.
Thank you all.
Thank you, ladies and gentlemen. This concludes the presentation. You may now disconnect.